Hello, everybody. Hi, Carolyn. Technical difficulties. I just called up Senor Internet. So I have a direct connection to the Grand Mistress of the Internet. No, I didn't really. I don't know what happened there. And, I don't know when we froze. Maybe you could tell. I was answering a question from Teresa, and I want to continue to answer that question. Maybe Teresa will pop back in here. How we individualize every single woman. And at the bottom line, um, Teresa asked, should she really start the estrogen before bringing in the progesterone, and what kind of balance do we use? And I used to do that because what I thought a woman would be best served by was her getting an internal feel what each individual hormone felt like. So we would always start with biased. And then once a woman said, gee, my hot flashes are disappearing, because that's a symptom of estrogen insufficiency. In fact, I'm not having any anymore. I would say, now we're going to start progesterone. But I abandoned that approach because I realized that the amount of estrogen that she was going to take in was going to be affected by the amount of progesterone she had, and that a woman's body was just not used to having just pure estrogen. So we changed our method only about 20 years ago, 23 years ago, from giving individual hormones to switching and at least starting with biased for the estrogen, plus progesterone for progesterone. And we do that all the time. And then lately, in the last couple of years, our questionnaire, which is so extensive, reveals testosterone insufficiency in so many women. What we know for sure is that there's no woman I've ever tested that 3 years with no period was not low in testosterone, and that is not okay. Testosterone is not a male hormone; it's a human hormone. Women desperately need testosterone, just like men desperately need testosterone. Oh, desperately? What am I talking about? No testosterone, you lose your muscles. Take a look at the thighs of women in their 80s and 90s. Or consider the loss of the ability to walk and stand with stability. Thus, canes, walkers, and then that challenging moment to switch to wheelchairs. That's from sarcopenia. Gerontologists know this. They tell you, I was instructed in this by a gerontologist that the bane of the elderly is really sarcopenia, loss of muscle mass. And then women and men can't stand with stability and can't walk with stability, and they fall and they fracture their hips. That was life-ending until surgery got so astounding. But still, they still only, on the average, last a year from what I've learned after that surgery, as was true for my mother. So mainly what I'm saying is the majority of women, now that we have so much experience with testing, the majority of women who are in the perimenopause have already drained their androgens. Why? Because estrogen and androgens are recruited for the biology of the fight or flight response. That's not their principal function, but they can really add to the power surge needed if you're chased by a saber-toothed tiger. I remember, Carolyn, when you and I were back there in the tundra running away from those beasts. I myself, I think if I remember correctly, I developed a way to calm them down when they're right in the midst of their attack, just by saying a few nice things like, you don't want to really attack me.
You were so brilliant.
Thank you. I had such a calming way with the saber-toothed tigers. If they
Thank
were,
you for protecting me 20 million years ago. I really appreciate it.
I
Indeed.
don't, I don't know if I'm entirely remembering that correctly. Do you remember it, Carolyn? Maybe I am remembering it correctly.
I remember it like it was yesterday.
Oh, yeah.
Kidding? And here we are again.
Yeah. So I guess back to the point that almost every woman we test in the perimenopause is also low on her testosterone. If you're getting flab under your triceps or you're down on the floor and you're not getting up so quickly because you got to use your arms, you're losing androgens. You're losing your muscles, and it's so common. Now there are a few women that still have healthy enough adrenal glands that as they go into the perimenopause and they start losing their estrogen, and this also relates to Teresa's question, they start losing their estrogen, their body has a compensatory mechanism. It can produce extra testosterone and it can convert that testosterone to estradiol. So if a woman's getting low on her estrogens in the perimenopause, she's got recourse. She can increase her testosterone production. And some women in the perimenopause, they start getting hair on their chin, in their mustache area, they start getting hair, they start getting oily skin and even pimples again. That's from an increase in testosterone, as best as I can interpret it. That increase is there to try and bring in more estrogen in response to the body's falling estrogen. And I can tell you this, that if there is a woman who's low in estrogen and is getting symptoms of increased testosterone in the perimenopause, if we give her estrogen, the testosterone comes back into the normal range. So I know I'm getting pretty esoteric there, but that was part of Teresa's question. But I'll tell you, the majority of women that we're seeing these days, they're in the perimenopause. They can't do that extra bump in testosterone because they no longer have the adrenal or ovarian power to do it. And my belief is, I have no scientific proof of this, that there's just placed too many, as all of us do. I'm not singling out women here. We place such heavy demands for the biology of the fight or flight response throughout our lives that by the time we hit the 30s and 40s and 50s, we just can't ramp up the RPMs of the adrenal gland. Don't have the oomph anymore. So, Teresa, back to your fundamental question. We approach it from a different way. We don't try and prefigure these things out. We do a very thorough medical history. It's going to give us a clue to how to start you on your bias, your progesterone, and very usually testosterone at the same time. We titrate the bias and the progesterone. We start low and we gradually increase those dosages with the intent of alleviating symptoms of estrogen insufficiency and progesterone insufficiency. Or if you go too high, you're going to produce symptoms of estrogen excess. All of this is totally spelled out in our book, Happy Healthy Hormones, that Carolyn's made available on the ins and outs of menopause, the PDF version. You can get a printed version if you want, but the PDF version is on ins and outs of menopause. We spell this out in great detail. And then a lot of women, again, like I've been repeating myself here, we're going to start on a combination of testosterone and DHEA. So women in the menopause method, they get 3 different bottles, a bias bottle, a progesterone bottle, and a combination of testosterone and DHEA. We're going to keep that testosterone and DHEA at a steady dose. I'm not going to try and titrate that one at the same time. And then once you've titrated in the estrogen and progesterone, we're going to test you. If you're in the menopause, we're not going to test you in the perimenopause, but that's a different question for a different day. So Teresa, I hope that I hope you're back in there, and I hope that you can that answers your question. And hi, Sal.
Oh, Sal's so lovely. Teresa's, all of our women are lovely. You're lovely, and the men are lovely too. And I'm so glad that we finally hooked up a trip around the world this morning. This is, I'm glad that you did answer that, and I'm sorry I couldn't hear the beginning part. But I think that this question might come in well here, because we speak a lot about high cortisol, a lot. But the questioner is saying, may we speak about low cortisol? How does this happen? What can we do to fix a low cortisol problem. I did a saliva test that showed that I have rock bottom cortisol, and this is really scaring me. Do you think that you can help explain this, Dr. R?
Yes, good question. Again, I don't know that there's ever been a question in all this time that you and I have been answering questions that has not been a good question. That's a good question. Cortisol. It's produced by the adrenal gland, and it's the most important hormone in our body, so to speak. They're all important, but we can't, in order to live, we have to have enough cortisol. President John Kennedy did not have enough cortisol. He had something called Addison's disease, which is super low cortisol. And he had to take cortisol in order to live. Now, that's a very unusual, very, very unusual. Dealing with women for 25 years, I've never run into an Addison's disease. That doesn't mean they're not out there. They would go to an endocrinologist usually. They would have some severe symptoms. But I've definitely seen a lot of low cortisols. And since we do 24-hour urine hormone testing, we get a real clear picture. I'm not a real fan of saliva tests, as you've heard, and especially for the ovarian hormones. No, 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 no. Especially for a woman that we're treating with ovarian hormones. But for a woman who we're assessing cortisol, there is value in that saliva test. There's reasons why there is. And so seeing low values on saliva tests of cortisol, that's significant. We just don't want to dismiss that. Now, since we test hundreds and hundreds and hundreds and hundreds of women, I've seen low cortisols. And we don't just test the cortisol. In order to get a clear picture of cortisol, we want to look at the whole family, because there's the parent hormones, and then there's what the hormones become in the process of being utilized. Those are called metabolites. So there's a family of hormones called the corticosteroids, which includes the parent hormones and the metabolites of those parent hormones. The parent hormones are cortisol primarily, also cortisone. And there's three principal metabolites. And we like to see the whole family, because you could have a decent blood cortisol, but the metabolites could be low, and that could be a real warning that your body's taking measures to conserve the parent hormones. And so that means there's a real strain on your system there. And so the 24-hour urine hormone test reveals it all. And I'd say 10% of the time, these are wild guesses, 20% of the time, somewhere in there, we're testing a woman and she's got low corticosteroid family. She's sitting on the low end or below normal of cortisol, whoops, and her metabolites are low as well. We see this commonly. Now, here's the interesting thing. Well, let me address part of that question. How do they get low? Well, the whole purpose of these hormones relate primarily to basic functioning of the human body. The purpose of having cortisol and corticosteroids and estrogen and progesterone and testosterone and thyroid and all these hormones and DHEA is for the proper normal functioning of day-to-day activities. That's why we have these hormones. That's their job. Now, they've got a secondary job. They're so powerful that back in the day, before I learned how to quiet those saber-toothed tigers down and just get them to meditate, lie down next to us and just hang out in the circle as they were purring, saber-toothed tigers purring, before I got that skill, they would trigger in myself, for sure, a powerful internal response called fight or flight response, meaning I could either choose to fight the saber-toothed tiger, not my first choice, or run from the saber-toothed tiger, not an exciting second choice. But in order to fight or flee from that saber-toothed tiger, I had to inaugurates the most powerful internal biology I could possibly produce. And at the vanguard of that mobilization is cortisol and adrenaline, these two powerful adrenal hormones.
And it happens like that, right?
Oh, it does, like that. And not only that, these things are so powerful, moms have been known to lift cars up off of entrapped people. That's how strong can a mom get? Get her upset and she can get mighty strong, enough to lift a car up. And how is she biologically capable of doing that? Because of these the most powerful biochemicals in our body. And that stress response is led by cortisol and adrenaline. But those are not the only hormones recruited. Any hormone gets on deck. It's time for any hormone that can add power to get on deck. And estrogen and testosterone in a woman's body can also add to that, the power of that biological stress response. And so all these hormones are recruited, including thyroid hormone is recruited. How do people get low cortisol? It's pretty hard. You got to be overtaxing that adrenal gland day after day, year after year, decade after decade to get it really low, because the adrenal gland, that cortisol in the adrenal gland is the highest value and is thus considered the highest priority. So preserving your adrenal ability to produce cortisol is the highest priority going.
But how do we not tax it? I mean, like people don't that I have known of don't run around saying, I need to check my cortisol today. Yet, like we don't really.
Well, we do tax it. That's
test.
You can tax it enough, you can over-recruit this biology, the stress response enough that eventually the glands can't keep up with your demands.
I mean, is that like through stress or is it through? Okay.
It's because any form of stress, even worrying about whatever you're going to worry about, also will trigger the biology of the fight or flight response. Worrying doesn't look like you're running from a saber-toothed tiger, but internally you're frightened and you're activating the same stress response. And you do that for as much as human beings tend to do that. And many people enter midlife with compromised adrenal glands. They've been overtaxed and they cannot produce the youthful levels of cortisol and corticosteroids. And it's so common when we test a midlife woman, we only test her by 24-hour urine hormone testing. We only do that testing once we've replenished her ovarian hormones. And she's not in the perimenopause. No, she's in menopause. And we've replenished her ovarian hormones. We want to get an exact read of what's going on in her body. We're treating her, and we want to make sure that she's in the optimal zones, because symptom alleviation is not enough. 75% of women who are very satisfied, symptoms alleviated, 75% of them are not in the optimal zones. So we always do the 24-hour urine hormone test. And when we test these women, like I say, 10 to 20% of them have got low corticosteroids. But here's the interesting thing. If they're not too low, the mere act of replenishing the estrogens and the testosterone and the DHEA and the progesterone, the adrenal glands will recover and start producing enough cortisol again in the optimal zone.
That sounds good.
So 90% of the women who we test that we have low corticosteroids, we see them. We saw the low estrogens, we saw the low progesterones, we knew it by their symptoms. But even when we see the low corticosteroids, they're not abysmally low. They're low, but they're going to recover just by 6 to 12 months or even 3 months to a year and a half of replenishing the ovarian hormones. The corticosteroids are going to recover all on their own. So nothing to be frightened of. If you're walking and talking, your corticosteroids, even though they might have shown up low on the saliva test, do not worry. Because if you're walking and you're not staying in bed all the time, the likelihood you got enough corticosteroids to get your basic work done. Now, I did not say 100%. There's a certain percentage of those women who show up with low corticosteroids that we need to supplement cortisol. We need to treat them with cortisol for a while. Interestingly enough, in last week's grand rounds, where physicians and nurse practitioners and prescribing compounding pharmacists who are using our methods, they attend grand rounds. And one of our medical doctors presented a case where she chose to treat the woman with a low dose of cortisol because the replenishing of the ovarian hormones were not getting her energy back. And she saw her numbers, and she chose to treat her with 5 milligrams of cortisol. We never treat higher than with 20 milligrams of Cortef or cortisol. You never have to go higher than that. And she elected to treat this woman with 5 milligrams of cortisol. And when this woman did receive the cortisol, she revived majorly and made an obvious major clinical difference. This medical doctor was challenged by another medical doctor in the grand rounds, not me. I agreed with that treatment of the 5 milligrams. In this case, just in this case, and because medical doctors were frightened about giving cortisol. In the 1960s, I left medical school with fear of one drug, cortisol. Because when it was discovered, doctors started treating a lot of patients with it, and patients loved it. And they were these tremendous doses were going out the door because why did patients love it? Because there was a widespread overtaxing of adrenal glands, and they luck in the cortisol. And also, people get high on cortisol. Uh-oh. So if you can go into overdose, you can get high on it. Nobody knew their dosages.
I mean, is that like a speedy high or a just balance?
No, it's a high. Not everybody gets high, but even on overdose of cortisol, you can get high. You can feel how do you define high? I'm not going to define high. You feel good. You feel super good. And unlike other overdoses of other hormones, you usually don't feel good at all when you go into an overdose. But elevated dose of cortisol, you do. So it really scared people because they started getting side effects. Doctors started noticing that people were getting side effects from excessive cortisol, egregious side effects. So it put a fright in the medical community. And one medical doctor wrote a book called Safe Uses of Cortisol. He said the problem wasn't treating people with cortisol. It was an overdosage problem. Just don't throw out the baby with the bathwater. When people actually need cortisol, you want to treat them with it. Just treat them with the right dose. So this physician who presented at grand rounds did choose the right dose. This patient got tremendously better. And on the caution we always say with anyone who's treating with cortisol is keep your eye on this patient, test her every 3 months, because there's going to come a time where she's going to recover, and she's no longer going to need to be treated with the cortisol. She will continue for a lifetime to need the estrogen, progesterone, the testosterone, and whether you're treating her with thyroid or not, she's going to continue to need all those hormones, but high likelihood she will not continue to need the cortisol because her adrenal glands are going to recover. They're going to prioritize the cortisol. So we watch these patients, testing them every 3 months at least, because and what will happen? We'll see the day that it occurs that they no longer need the supplemental cortisol because they've recovered.
May I ask you, Dr. Art, is there such a thing as bound up cortisol and free cortisol?
Yeah.
Okay, just wanted to ask.
All these steroid hormones, they're fat soluble. So even though the glands are producing them, and even though the glands are putting them into the bloodstream so they can be distributed throughout the body, they're handled in a very special way because they're fat soluble. They can't travel around in the bloodstream in fat globules. Like, for example, if you look at your salad dressing, you're going to see little bubbles of olive oil or whatever oil you're using sitting on top. They can't travel around like little bubbles of oil. So they're bound, they're carried. The body knows how to do all this stuff. It's just astounding. The body binds the cortisol to plasma proteins, and that's the safe way to carry cortisol throughout the bloodstream. And so all these hormones have binding, are bound to, but that's usually not the issue. The binding is not the issue. It is in some of the ovarian hormones, but the cortisol binding is not the issue. It's you don't have enough cortisol. And a lot of times, 90% of the time, I'm making a wild guess, when we see low cortisol in a 24-hour urine, we know that this woman's going to recover and she's feeling good, so we don't treat her with cortisol. And when we test her the next year, we see, oh, look at that, her corticosteroids return to normal. Merely by giving her supplemental estrogen, testosterone, and progesterone, and maybe even thyroid. Look at that, the cortisol recovered all on its own. Happens time and time again. But
it's actually beautiful.
yeah, amazing. Because you're not just drawing on cortisol for the stress response and adrenaline. You get to now really continue to recruit the ovarian hormones if you're doing extra stress. And you haven't learned the trick that I learned with the saber-toothed tiger, which also applies to worrying. Oh, we're talking about worrying. Oh, where's the source of worrying? And how do you, like Mad Magazine said, what me worry? What me worry? Surely I'm dating myself. There's ways that
No, it's back out now, Mad Magazine.
there's ways that you do not have to deal with life stresses by triggering the fight or flight biology. What wonderful tools those are to acquire. Oh my God. They're life-changing. If you can heal the repressed emotions within yourself. So that's a whole other topic that we have covered from time to time. But the moral of this story is occasionally women with low cortisol need to be treated with cortisol. And just because the salivary hormones are low, in this particular patient, I'd have to know a heck of a lot more about her. And I'd ask her not to worry if she's walking and talking. She's got enough cortisol is low. But don't worry about it. Just get the proper hormonal balancing treatment, because that cortisol got low for a lot of reasons. And only a small percentage of women who test out low on cortisol are actually going to need treatment with cortisol. And if you get treated with cortisol, we watch these patients like a hawk. We test them periodically because there's going to come a time, if you replenish all the rest of the hormones, that they're not going to need that extra treatment with cortisol.
Well, thank you very much for that. And that then leads me into my next question. We have a little time. So, this question, oh no, where'd you go, Dr. R? I hope you can hear me. Oh, Dr. R, Dr. R, where'd you go? So, ladies, I think you can hear me. Can you hear me? Can anybody put on the chat if they can hear me? I guess not. Okay, we're going to try this again. But we will be back on Thursday, so we'll get to... Okay, you can hear me. So, just to let you know, I think Dr. Rosensweet's trying to get back up here again, or I'm going to try and get back up. We have about 10-15 minutes left. We will get to all of these questions again on Thursday. I don't know what the heck happened here. So, let me try and get back to Dr. R. Give me a sec. Be right back.
And we're back. Carolyn, maybe you have more pull with the internet than I do. Maybe you could call up the people in charge of the internet and tell them we need to not get interrupted.
I'm going to ask them if they know who we are.
Yeah, really.
I think that it was a weird happening just this morning because we don't usually have this. We have a few minutes left, Doctor. If we can do this quickly, we'll see. I'm gonna, but Thursday's here, so I'm gonna re-present these questions on Thursday.
Okay, great.
Um, yeah, they're good questions. And I appreciate your patience so much. And this is cuckoo. But nevertheless, and everybody's patients, thank you. Um, in the subject that we were talking about above, is it possible, you may not want to do this, but is it possible that you could explain the pregnenolone steal, how it is that pregnenolone is a master hormone, sort of like cortisol, but pregnenolone converts to progesterone and then to cortisol? That's very confusing to me, the questioner asked.
Well, it relates to something called a biochemical roadmap. And like, for example, we eat food and that gets converted to estrogens, progesterone, testosterone, DHEA, thyroid hormone, our food. And it does so through a series of steps. And there's a lot of them. And interestingly enough, all these fat soluble steroid hormones, I'm talking about the estrogens, progesterone, testosterone, DHEA, cortisol, they're all derived from a food source. Our body eats that food and converts that stuff biochemically into the steroid hormones, among a zillion other things that the body produces from food. Oh boy, want to believe in the divine? Study biochemistry or human physiology, because there ain't no explaining this stuff. And as a matter of fact, the food substance that it happens to convert all these hormones from is known as cholesterol. And there are certain people who are overdosed on cholesterol medications that get into serious, I mean serious trouble. If that cholesterol goes too low, they're not going to produce enough of these steroid hormones, and that's life-threatening. So cholesterol. So one could make the case, if you're low in hormones, just eat butter or other things that contain cholesterol. Well, I'm not going to advise that because we can't control it. We can't say, oh, well, you're low in biased, you're low in the estrogens, we'll give you butter and that will give you all the estrogens you need. No, because we can't control these complex biochemical interactions. Cholesterol gets converted biochemically in the human body to pregnenolone. Pregnenolone even has some wonderful biological activity. Like pregnenolone is very useful for the brain. But pregnenolone gets converted to progesterone, and progesterone can get converted to cortisol, or pregnenolone can convert to the other DHEA, and that can be converted to testosterone and estradiol. So this is where these biochemical roadmaps come in. I personally have never heard of the pregnenolone steal. I've heard of something called the progesterone steal, that since cortisol is produced out of progesterone, which is produced out of cholesterol, cholesterol gets converted to pregnenolone, pregnenolone gets converted to progesterone, progesterone gets converted to cortisol. The cortisol steal is, since your body has a much higher priority for functioning in the presence of cortisol, it'll use up all the progesterone just for the production of cortisol, and it won't leave enough progesterone. That's known as the cortisol steal. And maybe this particular questionnaire has got something where it even goes back to the pregnenolone. The pregnenolone is getting stolen, so to speak, for the production of the higher priority, life crucial hormone called cortisol. So people have made the case, well, why not give people pregnenolone and let the body do its thing, because we can't control it. So we never do that. I do give pregnenolone for people with cognitive challenges, but only for pregnenolone's direct effect. When we want to give hormones, we replenish the ultimate end product of these biochemical roadmaps, these biochemical pathways. We replenish bias, which is a combination of estradiol and estriol, progesterone. Make sure the woman's got enough progesterone. She's not doing the cortisol steal on it. DHEA and testosterone. And if we need to give cortisol, like we were answering before, we'll give cortisol. And lo and behold, I've got a hard stop on the hour.
And it is okay because even though we were around the world and back, we got great information as we always do from you. And we're so appreciative for that. Dear, dear Dr. R, thank you for your kind patience and for answering our questions. I'm going to re-ask many of these in the way that I presented them to you earlier on Thursday. So everybody have a wonderful day today. And write to me if you need to. You know where to go. And hasta.
Hasta.